Good morning, ladies and gentlemen. Thank you for joining today's third MAP webinar. My name is CAGURANGAN, and I am the chair of the MAP Sports, Fellowship, and Wellness Committee, which is the organizer for this webinar. Please settle down comfortably. We will now begin our program. May I request everyone to pause and bow our heads for a short prayer. Our most merciful God, we come to you in our weakness. We come to you in our fear. We come to you with trust, for you alone are our hope. We place before you the disease present in our world. We turn to you in our time of need. Bring wisdom to doctors, give understanding to scientists, endow caregivers with compassion and generosity. Bring healing to those who are ill. Protect those who are most at risk. Give comfort to those who have lost a loved one. Welcome those who have died into your eternal home. Stabilize our communities. Unite us in our compassion. Remove all fears from our hearts. Fill us with confidence in your care. In the name of Jesus, amen. Let us now place our right hand on our chest and join us in singing the Philippine National Anthem.
Joanna.
We're not hearing the sound.
Joanna. Maricel. Maricel.
Okay, thank you for that. I apologize for the technical difficulty. At this point, may I request the president of MAP, who is the senior partner and EXCOM member of ACRA Law, Attorney Francis Lim, to deliver his welcome remarks.
Thank you, Rack. Good morning, everyone. I hope that you and your families continue to be healthy and safe while we are all on a lockdown under the government's enhanced community quarantine, or ECQ, which is now extended to May 15. On behalf of the MAP Board of Governors and the staff of MAP, I welcome you all to this MAP webinar. Many thanks to MAP Sports Fellowship and Wellness Committee Chair CAGURANGAN and Governor-in-Charge Gigi Montinola, as well as MAP Governor JP ORBETA and our staff, led by Arnold, for putting together this webinar on developing health protocols for workforce re-entry. For the benefit of our guests and members for participating for the first time, aside from the online board and general membership meetings we conducted, this webinar, as RAC has said, is the third that MAP is conducted since Luzon was put on a lockdown. The first MAP webinar, conducted last April 2, I think, was on responding to COVID-19. The second one was on managing the workforce today and preparing them for the new normal, which was conducted only a week ago or on April 17. This webinar we're now having, and I understand there were 320 registrants as of 11:30 as of yesterday, is part of a series of webinars on COVID-19 related topics. We're planning another one, possibly on cash flow management, on a date to be announced later. May I also inform you that MAP has partnered with the business world for its series of Insights online fora. Please block off your calendars for the following online fora via Facebook Live for 3 consecutive Wednesdays from 11 a.m. to 1 p.m. The first one will be conducted on April 29 on assessing the coronavirus pandemic's impact on the Philippine economy. The second one, which will be conducted on May 6, will be on understanding the new normal for business after the COVID crisis. And the third one, on May 13, will be on the COVID-19 and the Philippine stock market uncertainties and opportunities. We will remind you about them. May I also take this opportunity to inform our members and our guests that MAP has submitted to the IACTF a proposal for a modified transport system that is envisioned to address the transportation needs in Metro Manila, both during the ECQ and post-ECQ period. The proposal is entitled Transition Towards the Normalization of the Public Transport System in the NCR, with initial focus on buses, LRT, MRT, PNR. Thanks to MAP's Traffic Transportation Infrastructure Committee, chaired by Rui Moreno, for working on the proposal. I'm also pleased to report that MAP submitted its position paper on the proposed bills, separately authored by Congressman Joey Salceda and Stella Kimbo, that seek to put in place a stimulus program to help revive the economy, as several countries have already done. The 2 draft bills cover the important sectors that deserve assistance from social and economic standpoints. They are comprehensive in coverage and specific in the total and sectoral amounts to be allocated. They boost aggregate demand at the household level by putting back purchasing power to them to help revive the economy. Their guiding principles essentially address the current and future requirements for economic recovery and growth, while at the same time aim at promoting fairness. We have proposed several major refinements, the details of which I will not bore you, but I will report on them during our general membership meeting next month. MAP is also participating in Project ARC, which is a private sector-led initiative to make massive testing possible through the Antibody Rapid Test Kit, or ARC, at the community level, a condition which appears to be necessary to help decide whether or not to partially or selectively lift the ECQ. Employers can also use these tests to help them determine who among their employees will be allowed to go back to or stay at work in the event of a partial lifting of the lockdown. What this test really is will be discussed in this webinar by our speakers. We're strongly encouraging our member organizations to participate in Project ARC. You have two ways of doing it: by implementing massive screening in your workplace and or in sponsoring massive screening tests for a barangay near your office on a purely voluntary basis. In closing, let us all learn from the speakers as they present a framework to help our firms put in place company-level protocols for health screening of employees in the workplace. Stay safe, keep healthy everyone, and enjoy the webinar. Mabuhay ang MAP, and thank you to one and all.
Thank you, Francis. Before we start the presentations and the discussions, I want to emphasize the following important house rules. As participants for this webinar, we would like to inform you that you are automatically muted and your camera video was also automatically off. You may submit your questions to the Q&A button that you see on your screen, and with the assistance of our MAP Secretariat, I will read the questions on your behalf. For your information, you will only be able to see the panelists or the speakers in their presentations, but you will not be able to view the other participants. Lastly, at any point during this online meeting, in case you lose connection, please join again by repeating what you did earlier in logging on or logging in for this webinar. I would like to thank our speakers for accommodating us for this webinar that is envisioned to enlighten all of us in developing health protocols for workforce re-entry. We have here, and we were very fortunate to have here, Dr. Maria Carissa Rizzy Alejandro, MD, Head of Strategy and External Affairs of Ayala Healthcare Holdings. We also have Dr. TERESITA CUCUECO, Assistant Secretary and Director for Bureau of Working Conditions, Department of Labor and Employment, or DOLE. And Mr. John Philip JP ORBETA, Managing Director, CHRO and Group Head, Corporate Resources, Ayala Corporation. For today's webinar, Dr. Alejandro, Dr. CUCUECO, and Mr. ORBETA will discuss the following topics for developing health protocols for the workforce. Number one, framework to consider for workforce re-entry. Second is understanding testing and its advantages and limitations. Third, the workforce risk assessment. And fourth, establishing your own re-entry protocols. Things to consider. The last 40 to 60 minutes will be devoted to answering the questions from the participants. In line with MAP policy, we will dispense with the lengthy introduction of our speakers. Our first speaker has to join a government meeting by 1 p.m., so we will have a separate Q&A for her right after her presentation. So you will post your questions already in the Q&A or as she makes her presentation. May I now call on our first speaker, the Assistant Secretary and Director for Bureau of Working Conditions of the Department of Labor and Employment, or DOLE. Let us all welcome Dr. TERESITA CUCUECO. Dr. Teres.
Sorry, sorry, I have unmuted myself. Again, thank you for inviting us, because we are now here to share with you. As you have heard earlier, the President did make a declaration on the that the ECQ, especially for the NCR and other regions, will be extended up to May 15. And in that same press conference, he also mentioned certain guidelines that must be presented and must be given by government. And the DTI and DOLE was tasked to look at employers and workers. And we are, of course, working together. It is going to be a whole of government approach, but we would like you to look at, you've mentioned it, I've heard it earlier, the new normal. It will happen, it has to happen, it will happen for a long time until a vaccine or a cure will be discovered. So even if they say they will lift, there is no old normal. We have to look into what has to happen, especially as now we're still on an enhanced, and if it will be modified, then there will still be, of course, certain actions that will prevail. And what is the new normal? We talk of the social physical distancing. in previous DOH recommendations as well as in the interagency recommendations, we really have defined it as a 1 meter radius from a worker to another worker. You can extend it, that would be better. Then you look at the wearing of masks. There was an interagency resolution that said everyone must wear masks. That is not going to be exempted in the workplace. It will happen. It has to happen. That is the only way of reducing transmission. And masks will be the new norm. Even before you enter the building, you will have to wear the mask. You will only take it off, and this will be part, I'm not sure if, you know, these guidelines, we are still proposing it, we'll be working together with the DTI. It will only be taken off during meal times. And that's why if you will see the new guidelines, there are even, and I think you have already seen certain guidelines where we are discouraging communal meals, where we just say, just take your meal by yourself because you will be removing a mask. And you might, and you know, we just want to take all precautions. Then there's work arrangements. It is going to happen. In the enhanced, it's still skeletal. We're still doing it. It has to happen. There are certain industries that were allowed. It is still happening. Skeletal workforce is the norm. And it will still be the norm because you can really achieve social distancing if there would be less. And there's, of course, the work from home, which now everybody should adapt to. Technology is something we should embrace. We are doing it now. It has happened. All our meetings are video conferencing. And this is really what we are, where we are and how we will be doing things, especially for workers who are vulnerable. I'm not talking only of the 60 years old. We're talking of those even younger with comorbidities. So this will have to, you know, all of this will have to be in place as we look into our workforce. Then before a workplace, we already have it, the workplace screening, thermal scan, and in addition to that, the health monitoring. I heard earlier your concern, I mean, the rapid test, or the test for COVID-19. It has to happen because it is the only way we can identify those who have to be treated, isolated, managed, because again, our success rate in treating will really have to happen early. We identify them early, they will be treated early, managed earlier, and we would have less seriously ill. But again, this should be looked into with caution. All tests are not foolproof. There will be, even the PCR, there will still be false negatives and false positives. The rapid test as well. So where are we? So that's why it has to be looking at all of this, considering everything, the workers, his health condition, how he feels for the day. That if you have rapid testing, but let me say, this is really something, this testing is, we are still getting our guidance from the national government on how it is going to be incorporated. But like I said, there are still other things we look into in terms of what should happen in the workplace. Can I go to the next slide, please? And this is now what the DOH requires as the minimum health standards. Of course, we would like a healthy workforce. What is increasing physical and mental? This is already in the DOH minimum standards. And if we put them now in the guidelines for the workplace, this is there. We are also addressing it through what do we mean by increasing physical and mental resilience. We are looking at, of course, nutrition, physical activity, mental health, and of course that there is basic needs inside the workplace, water, sanitation, and of course promoting the welfare of the workforce. The second, on reducing transmission, the PPEs. We talk of masks, but remember there might, if you talk of the healthcare sector, then there will be other PPEs that would be needed. Even in your clinics, it's not going to be masks alone. They would still need other types of PPEs. So PPEs as appropriate, but masks is definitely one of, it is the general PPE for all. Then it would look at access to basic hygiene facilities and supplies, frequent hand washing. We will not overemphasize this. Hand washing is really key to ensure that our hands are clean. We do not transmit the disease, from what we touch to our bodies, um, uh, places in our face where the virus can then enter and cause disease. And of course, that would mean discouraging touching of eyes, nose, and mouth, and disinfection. It is going to be that we have disinfectants everywhere. Soap water is in all the comfort rooms. Then of course on the third, on minimizing the contact rate, that is physical distancing. We're still banning public gatherings. Schools will be closed. There should still be the physical reporting of personnel. We should reduce face-to-face encounters. And that's why even in meetings, if it has to be prolonged, it's better to do teleconferencing, video conferencing. Reducing movement from work areas. You're looking now at unidirectional. If this corridor is to go the right side, another corridor to the left, so that you will avoid face-to-face. And then if there are stairs and elevators, you have to consider, that's going to be part of the guidelines. There is and has to happen that there is social distancing even in elevators. You might ask, our elevator is so small. Well, there must be stairs, there are the elevators. So if you have to understand that we are trying to do everything to reduce contact, all of this must be factored as we look into the safety and health of the workforce. The stairs, if you have two, one is for going up, the other is for going down, so that again, that face-to-face contact will be reduced. Then improving ventilation, having good ventilation, replacing old air with fresh air, that is going to be very good, and protecting the high-risk groups. Again, we will go back to what we said on work from home arrangements. Then on the reducing the duration of infectiousness, here we have to address those who suddenly would have symptoms. During the workday, if they suddenly feel unwell, what will they do? What protocols will be followed? Then of course, there would be contact tracing, quarantine, teleconsultation, telemedicine. I hope this is going to be taken up by Dr. Rizzy later. And of course, the referral of symptoms. So looking at all of that, this will all be part of the guidelines. We are glad that, as DOLE has been formulating our guidelines and we saw this minimum health standards from the DOH, it is aligned. We now have to share it and we have to work on it as together in government. There's a DTI who has to work with that we have to work with, and us, and we're looking at, and this is why I also have to leave after this, because I have to present it now to our DOLE officials, so that from this document, it will now go to the DTI and to become one of the guidelines that will be issued. So I am giving you a preview, but this, I couldn't give you any more because they're all drafts, they're still proposals, and from yesterday's learning, there's so much leak. But because we have to guard, we are very careful, because everything that even as we give our policy directions, we have to consider certain, of course, evidence-based. We have to consider that everything we put down would have basis in fact and in medicine. So with this, I hope I have shared with you what is now the new normal, what our guidelines will look at. And with that, we hope we will be able to rise together. And finally, if this all ends, we still have, of course, to now look at how we are going to improve the health of our workers and, of course, the safety of our workplaces. So thank you for giving us this time to share all of this with you.
Thank you, Dr. Tess. I know that you have a 1 o'clock, but I think we have time.
No, it's actually at 10:30. It's
Oh,
together.
oh, it's together. Okay, so how do we do this? There's just at least one
No, it's
question, I
okay.
suppose.
No, it's
Okay,
okay.
so
It's okay. I already said I'll take this first and then I'll go back to the next.
okay, all right. So let me just ask you a few questions. There are many actually right now. But
Go
the first
ahead.
one is, Dr. Ortiz, for employees' safety, especially those working in highly populated areas, Makati buildings, manufacturing, what's your take in companies investing in, number one, providing flu vaccine to employees? Second is washing facility at the work entrance and disinfecting entrance, as
Okay.
being used in several government units.
Okay, flu vaccine, I think that is, we the ordinary flu or the flu, that is still a protection. We have no, and it is encouraged to have that as well, but please, let's not have the sense of, no, if we have that, we're also protected from COVID. We just don't like that kind of perception will happen. It's not, if you are vaccinated for flu, the ordinary, then that's just for that. It's not for COVID. So I think it is still it is a good practice for companies to continue. On washing facilities before entrance and the disinfection, these are additional costs. If, soap water, if they want to wash it, they want it before they enter, fine. That's if it's just soap water anyway, but as long as it's there, I mean, it's added on, that's good. But on disinfection, and that's why we also have to vet on the disinfectant foot baths, the misting disinfection. We leave that up to you. It's your policy. These are additional costs. But again, we look at, it might assist, but in that long term, there are other measures that have also to be properly done inside the workplace as well. And even, going out, if you have to change your clothes and maybe those things, and this is really special for the healthcare workers, those protocols should be in place.
Okay, those questions were asked by Ida Tiongson. Here's another one from Joan Mar. What is the status of the government study on the Telecommuting Act or the Alternative Work Arrangement Bill?
It's not a bill, it's a law. It is
already a law.
Yes, it is a law, and we have an IRR, but it is voluntary. We did not, it was passed last year. The Telecommuting Act has passed. It's a Republic Act. I just forget the number. The IRR was passed as well. But because it is voluntary, but we will be issuing guidelines that we are promoting this now, even if it is voluntary. We would like that companies have an agreement because, when you do telecommuting, it's not just saying that there are deliverables. You will ask for outputs because this is work that is not done in the office but at home. But in our IRR, there were situations where we were asking, where it is also stated that once in a while or occasionally they would have to go to the office. But again, because of this situation now, the present situation, especially those vulnerable, they may not go to work or not report, but deliverables should be agreed upon at the outset, so that even if there's work from home, it is work that is going to be done. Okay. But it is still voluntary. Look at it because there's also safety and health there. Because if you're going to do work from home, it's 8 hours work. And that means you have to have a good workstation. It's hard not doing this, and I'm doing video conferencing like sometimes straight 8 hours. It gets
actually, it's more difficult to work from home, actually.
Exactly.
There's so many distractions. Okay, here's another question from JP Orbeta. Once the ECQ is lifted, actually it's from his HR, I think. So once the ECQ is lifted and employees are allowed to go to work, can an employee refuse to come to work due to safety concerns or fear, even if he or she is designated as an essential or critical to operations? And if so, what are the options of the employer and employee?
Okay. The first premise is if the ECQ is lifted because, is there a vaccine? And that means really the possibility of getting sick now from this, or, we're talking of a protection of everyone and there's immunity from this disease. So if that is the scenario, then, we have to go. There are work standards that must be met. But if it is lifted for but you know, allowing certain workers, again, there will still be vulnerable workers unless the vaccine is found. So we have to weigh this in. In fact, in our proposal, certain policies, HR policies, should be looked into, because you have to address this. There are company policies that, you know, is it justifiable? Is it because you have to allay fears? We've seen surveys that have been done by NEDA, and the health fear is so predominant. So again, we look at companies to see how best you can answer this. What are so that you can, you know, look into if there are justifiable reasons, then how will you be able to do this?
Okay, so these are questions. The next questions are from Reggie Casta, and I think 3 out of 4 are answerable by yes or no. Okay, sports clubs or health centers. Will the government include sports clubs to reopen upon removal of lockdown?
Actually, you know, if you've seen that, you know, I was just so amazed by the leak. Because I never had a copy, but everybody had a copy. But it's like, because I mean, I have been part of the interagency meetings as an observer, but you know, it's really, if they say it's top secret, we don't look at it. But I'm just so amazed. Anyway, leisure activities, then I would look at sports. They're not yet going to be allowed. You would have to find exercise activities that is allowable. You know, walking. I know it's going to be hard, but if you have a garden, you can do badminton in your own place, or then maybe you can look at that. You have to be creative. You have to, but again, if you're looking at going to gym, it's not yet allowed. Even actually, there are certain, like public gatherings, it's still not allowed.
So tennis and badminton possible?
No.
No ren. Okay, so I suppose...
Unless you have a tennis court in your house.
Okay, well, the other question that Reggie has is on this. Now, we are reducing manpower to reduce costs due to anticipated decline in revenues. Employees on recess will not be compensated due to no work, no pay. Is this fair?
Okay, again, can we go through it? They have reduced workforce.
Okay, so they reduced manpower,
yes,
because in order to reduce costs due to anticipated decline in revenues.
Yes, okay. And then the question is,
employees on recess will not be compensated due to no work, no pay. I suppose these are the ones that are staying at home because of various reasons.
Because now, because of the reduced workforce, they're not, you know, I think you all know that our camp, the COVID adjustment measures program would have been the way to provide that financial assistance. But again, we still have the Department of Finance, the assistance provided. We hope that, I mean, I know if they are remitting to the SSS and the BAR, they will be given. So please look at this. The president, our secretary, the secretaries have been appealing to companies, but we also know that if companies can no longer afford, it's hard. But that's why the financial assistance from government kicks in. So please go through the financial assistance that is now the small business wage subsidy. There is still for workers who are not anymore receiving their wages, they can be assisted through this.
Okay, so it's really, so in sum, it's no work, no pay being implemented.
Yeah,
okay.
It can happen.
Here's a related question. In President Duterte's press briefing this morning, and this is from an anonymous attendee, it was mentioned that part of the guidelines of provinces under general community quarantine involve asking individuals 20 years old below and 60 years old above to remain staying at home.
Yes.
What is the possible guideline that DOLE has to implement concerning these groups? Will employers be allowed to do early retirement program for workers in 60 above or retrenchment?
Okay. You know, that's why when I remember in the new normal, the work from home, if they still want to work and you can accommodate them in doing work from home, please do so, because that is really, they have to be to, these are the vulnerable groups. And we're not talking, that's kulang pa, because if you see the whole thing and it's all going to come out, there are those in any age group, but with comorbidities, meaning if you have hypertension or diabetes, you are vulnerable, or high-risk pregnancy, you are vulnerable. You should stay at home. So considering that this will be a significant number in our workforce, we would like, of course, that there would be arrangements that they can continue to be productive, they work from home. But if you also have packages that they can look into, like early retirement, other types of company benefits that you can then provide, we leave it up to the company. But really, if they're productive, please allow work from home, make the arrangements, and let's pray for that vaccine so that they can all go back to regular work.
Okay, what about ending the contract of staff who are on probation but did not report during the ECQ, even if they were provided with transfer and accommodations? Can we end the contract of these staff?
I think this would be like the probationary, the probationary staff.
Yes, the probationary staff.
Oo, pero may due process din pa rin yan, di ba? Kasi 6 months. Please follow. It's still, standards, library standards should still be followed. Even if you're in this period, we also have to, there might be some labor standards that we have to modify because of the situation. But if you have their performance was not good, or because this is probationary, so there would be assessment after 6 months. Please take a look at that, because again, due process is really, of course, part and parcel also of rights of workers as well.
Okay. Okay, so let's go now to test kits. Test kits being inconclusive. I suppose this is in referring to doing the screening, test for employees. Do you advise using it for employees, the test kits? I know in Project ARC yesterday, both the PCR and the antibody rapid tests are being encouraged, so the question from Nick Lim is, because, or at least at this point, test kits are inconclusive, do you advise that we still use it for the employees?
No, it's okay. We would like sana to get our from the DOH, because then they would really be that guidance would come from them. But we have been talking to them, and they also have been talking with industry, and we see that industry would like to take care of their workers, and they would like to have healthy, at least they have been screened, even if it's we would say it will, the false negatives might be there. But what we're saying is you can use it together. It's up to you. But there should be ways of really monitoring the workers well. If you, the thing here is on the cost of the test kits and the PCR, which is really a little bit more costly. If we say we encourage, but employers should pay, if you have 1,000 workers, that will translate to, of course, an amount of money. But if the employers are so willing, but that should not be your end all, because they might have negative now, but if they had a visitor later in the day or tomorrow who might have symptoms, then that's why we look at the daily health monitoring. We hope and it's going to be part of our guidelines that workers, before they enter, should always fill this up. It's the monitoring health guide, so that their questions, they should answer it really honestly, will give you, what are your workers feeling today? Have they been exposed? So that you can take the proper precautions. So test kits together with this, or this should, like I said earlier, it should be done in a holistic manner, but you cannot just say test kits alone. It might give you a false sense of, or might make you complacent, and you might also still end up having certain cases. So
there's a question also on the frequency, Doctora?
Huh?
There's also the question on the frequency on how often we will do this screening, because there was a question yesterday about that. It's not just one time that you will do it. You will have to constantly check, I suppose, in And how many times do we do that? And the cost.
Yeah, and the
associated
cost.
with it.
That's why everything has to be factored in. You know, when this has also been really a burning issue with the interagency, let me tell you. But then, of course, to determine as if a person is sick and having COVID, that we see the benefit of the kits there, and to monitor, you know, if he's getting well or he's already now negative. But to bring it out for you know, a working population or for a sector, it has to be done in a perspective that that's why it's really company policy. We're still looking for the guidance, but then, you know, even if you want to do it, that's fine, but make sure you also have the guidance needed to make you understand what this means and how you should be proceeding from the results of a test.
Okay. All right. So there's one more question, just one last question for you. Other questions, I think, will have to be directed to the other speakers. But for just one last question pertaining to the COVID, this is the camp.
Yeah.
Okay. And that there supposedly DOLE already advised that you have stopped accepting applications last April 15.
Yeah.
But since now with the extension to May 15 for NCR and Region 4, 3 and 4A, will the camp be open again to accept applications to assist employees?
No, I know. When the camp ended, we also knew that the DOF, the Small Wages Business Subsidy Act, will come in. So unless there are, because naubos na rin talagang pera. Actually, the DOLE was using its budget already to fund the camp. But like, remember, in this morning's meeting, that was why the president was asking key people to say, is there still money? Because really from us, it's like we have our budget, but these are also budgets for other programs, but we had to do. Now, if there would be, and the president would approve that it will continue, then fine. But for now, I know what's kicking in is the Small Business Wage Subsidy Program. And they were already looking that it will be applied for May. So even with the extension, this is what is supposed to be applicable.
Okay, so there are many questions, Dr. and we'll find a way to send them to you, and hopefully we can have some response to them, and we can share that Arnold to all the participants and all the other MAP members, right? So thank you, Dr. CUCUECO, for sharing your time with us today. Thank you so much.
Thank you. It was nice being. I thank you for the invite. I have to leave.
Okay, and thank you. I hope we can get the guidelines very soon.
Yes, it has to come out. We were given deadlines too. So it's
okay. All right.
Thank you very much, ASEC.
Thank you.
Okay, thank you.
Bye-bye. I have to leave now. Bye-bye.
All right, bye-bye. Okay, so now at this point, may I now call on our second speaker, Dr. Maria CARISSA Rizzy Alejandro, the head of strategy. Yeah?
No, I'll take the intro first, and then I'll pass it on to Rizzy. So I'll start the
introduction
conversation first. Yeah, with a couple of slides already incorporated with Rizzy.
Okay.
But yeah,
so
go ahead and introduce Rizzy. Go ahead, introduce Rizzy.
Okay, so all right. So both speakers, I suppose. Now, starting with Dr. Maria CARISSA Rizzy Alejandro, is the head of strategy and external affairs of Ayala Healthcare Holdings, and as mentioned earlier, JP ORBETA will be introducing properly Dr. Rizzy. So now may I call on JP to introduce Dr. Rizzy.
No, well, Rizzy, actually, it belies her age because I knew her parents. I know her parents back in school. So it's really great to have her as a co-worker now. And she really has been the thought leader behind a lot of these discussions around healthcare protocols. Now, I know there are a lot of questions on testing. And so that's exactly what we will be covering here. But maybe let me start. Can we go to the next slide to show our outline? We were going to talk on four. Who's running the presentation? Okay, we have four items in our agenda. I'll start with talking about the framework to consider for workforce re-entry. Rizzy will then take number 2 and number 3, which is understanding testing. What are disadvantages and limitations? And there are limitations. But I think our philosophy with testing, as she will see later on, it's better than nothing. And I think as long as we're able to manage the results and the findings, our philosophy here is you miss all the shots you don't take. And so that's sort of like how we've decided our approach to this whole issue. She'll also talk about the workforce risk assessment, both from a medical as well as workplace, and I will also chime in on that. And then we'll both talk about number 4, which is how we can look at establishing your own re-entry protocols. So game.
JP, sorry, would you mind if I just switch over to my slides? I think we're just having some issues navigating through the slides. So I'll just switch to share my screen. I think it's Joanna. Joanna, if you don't mind, if you could stop sharing and then I'll just share my screen. Thank you. Sorry about that. Let me just pull it up.
Great.
Okay, go ahead, JP.
So you're gonna drive. So you can show that maybe just to start, no. This is the framework that we looked at the Ayala Group very early on, no. In terms of just looking at how we look at this whole situation, and it was really how do we prepare for a post ECQ or what people fondly call as a lockdown scenario, and we really looked at 3 phases. No, one is the preparation for re-entry, and here we specifically didn't choose a date because we know that they were talking about April 1st, April 14, and then it was going to be April 30. Now it's May 15. Again, we still don't know if that's a hard deadline. No? So whatever happens, basically we said we need to start preparing for eventual re-entry whenever that is going to happen. And so when we're looking at that, it's really how do you keep our employees safe? How do we take care of our customers today? Because as you know, we have large customer bases in our businesses, Globe, BPI, Manila Water, AC Energy, AC Health. Those are all consumer-facing functions. So how do we take care of those customers today? And how do we change our operations? How will we adapt? No? So for example, at BPI, of the 800 branches, about 200 have remained open. But then you still have, or around 300 have remained open. But definitely the need is still there. No? So how do you make sure that we continue to serve the needs of the customers? No? And then from an offensive side, how do we maintain and maximize productivity? How do we continue to inspire customer loyalty? And how do we make sure that we improve operations as well for the future? So all of these things about working from home, increasing productivity, getting people used to Zoom meetings and Microsoft Team meetings, that's all part really of that productivity question. So the second phase is really talking about the modified community, the modified lockdown or the modified community quarantine. And this is the day it is lifted. Basically, we will still be in highly contagious conditions. Still, the virus is still going to be fairly active, and therefore, it increases the chances of actually getting exposed to it. No? Once the quarantine is lifted. And so again, from a defensive standpoint, what we've asked all our businesses to do are what are the scenarios, so worst case, best case, base case. How do we ensure that we can retain some of our customers and their trust? How do we optimize operations? That is the same period that we will have to look at. Will customer behavior change? As Sec already said, even if you do start opening some establishments, will people want to go to restaurants? Will people want to go to movie houses? Even though the restrictions have already been open. So even that period is for us is really a learning period as well, because we need to now recalibrate how consumers and how customers will be looking at the world. No? We're also going to look from an offensive side, how do we keep our employee morale high? How do we regroup and generate customer demand? Obviously, for example, in real estate, nobody's buying real estate, nobody's buying cars. How do we adapt to that? How do we maximize also our cash position and preserve cash? To be honest, that second phase, we also don't know how long that's going to be. ASEC already said that it's until a new vaccine is going to come out, and that can take anywhere from, gosh, 9 to 18, 24 months. Rizzy will be in a better position to say how long that's going to take. Normally, a vaccine takes 10 years, I think, is the norm before a vaccine comes out. No? So even that new normal is really a TBD. How do we transform our businesses now to adjust to that new normal? How do you balance well-being and productivity? It was already mentioned, how do you practice social distancing? We feel that social distancing is going to be a norm. And therefore, it behooves us to rethink of office workplace density and even how we conduct meetings and whether meetings, face-to-face meetings, should really be discouraged and shift to balancing between virtual and people joining remotely and face-to-face. How do you reallocate resources to support this new business model and the new plans? No? And of course, how do you transform the existing workplace norms? What was already mentioned earlier by ASEC about wearing masks. Is this something, I think, while that may be lifted in the new normal, I think hand sanitizers is the new norm. I think we will have people that will now be, workplaces will have a lot of hand sanitizers. Again, just this whole benefit of being more health conscious. So these just wanted to share that I think it's helpful for us. We found this very helpful to think of that in the 3 buckets. Rizzy, maybe the next slide. Really what we're looking at now is looking at the 3 buckets in terms of employees, customers, and operations. No? These slides, by the way, will be shared, so I won't go into that. But again, I already mentioned some of it. How do we keep our employees safe? How do we take care of our customers? How will our operations adapt? And from an offensive side, how do we ensure that we maximize productivity, improve continuous customer loyalty, and improve operations? So what we've done on the next slide is really created what we're calling a 4T framework. Sorry, the lack of creativity here in coming out with a name. But we basically said that there's really 4 phases in how we look at this now. The first is triage. And for those who know the medical term, it's really to determine and filter who needs to be treated, what's the seriousness of the situation, on whether they could be cleared. So the first one is triage. The second T for us is testing. And Rizzy will talk a lot more in detail about the testing. But really what we're saying is that we are going to establish as a group employee testing protocols, both rapid tests as well as confirmatory RT-PCR testing. The third is all about treatment. What happens in the event that an employee is found positive for the virus? How do we now make sure that that employee is undergoing the right treatment? How do we now, which leads to the 4th T, which is the tracing. How do we now make sure that every body in the workplace that have been in contact with that person can also be assessed? And notice it goes back to the triage, because then we need to do that first assessment all over again in terms of finding out, are they symptomatic, asymptomatic, what are their healthcare conditions, etc. And we're really looking at technology to help us manage that whole thing. So the next slide really just talks a little bit more about our resources, and maybe I can pass that on now to Rizzy, so she can actually start looking at the assets that we're putting at play here.
Sure.
Rizzy?
Thank you, JP. Thank you, everyone. Good morning to everyone on the call. I guess a big thank you to MAP for inviting AC Health and the Ayala Group to share our thoughts and ideas with you today. I'll just build on the 4 Ts framework that JP was talking about. Basically, in the Ayala Group, what we've done is use the 4 Ts framework to guide our own response efforts. And I guess we've borrowed a page from public health a little bit, where we've tiered it using the 4 Ts as a guide. At the bottom of the pyramid, our priority, as JP has reiterated, is to keep our employees safe and to keep everyone who's healthy. At the second tier, it's to be able to identify anyone who's potentially sick. And that's really supporting the broader testing efforts of the government and the Department of Health. Finally, at the top tier, it's anyone who is sick. We would make sure that we'd be able to support them in getting access to medications, inpatient treatment, critical care facilities. And so we built our priorities around these goals. You'll have to be a little creative with me. We're starting from the bottom, A to G, all the way up, just because the pyramid is the base and really that's the larger population that we're hoping to keep healthy. But you can see here that we have various initiatives happening right now across the group. Just maybe to highlight some, as part of our triage, the first T, we've set up an Ayala group hotline. And so anybody who feels symptoms or maybe is afraid that they've had an exposure can just call that hotline and be connected to a medical professional who can give them advice. We are also setting up a re-entry survey that we plan to do online. So this is in preparation for that modified scenario, which JP mentioned earlier. So we would help triage or assess our employees as to who can safely come back to work. At the second layer, and what we'll spend bulk of the discussion on today, will be our testing strategy. And I'll save the bulk of it for later, but maybe just as an introduction, we'll talk about how we're planning to combine rapid antibody testing with confirmatory testing, using a selective approach to sort of create an additional layer of screening or assessment for our employees. Finally, at the top layer on treatment, we recently just announced that we're helping to capacitate facilities that would cater to COVID-19 patients. One of them is Qualimed Santa Rosa in Nuvali. So this is going to be converted into a dedicated COVID hospital, a referral hospital. Right now, we're already seeing COVID-19 patients there, and we hope to slowly upgrade their facilities. We also contributed to converting the World Trade Center into a community quarantine facility. So for suspected cases or mild cases that need a place to isolate. So broadly, I think what we want to emphasize here is that if you're thinking about testing, it should really sit within a broader framework, and it cannot just stand on its own. You really need to be thinking across the 4Ps. So I'll take a step back and wear a little bit of my doctor hat and take you through more on the principles of testing itself. And I'll try to give you a crash course. Some of the slides might be a little bit technical, so I apologize if I try to fit a lot of information in the short span of time that we have with you. But I think the headline here is really that in the same way that COVID-19 is emerging, testing on COVID-19 is in itself an emerging science as well. And so we've tried our best to put together what we know and what we don't know about it. So right now, how you would be diagnosed with COVID-19 in the Philippines is primarily what you're seeing on the left-hand side, which is RT-PCR. Now, RT-PCR is the current confirmatory test. It's short for reverse transcription polymerase chain reaction. It's a mouthful, I know, and I've tried to simplify it on the diagram. Basically, they take a sample from you. So this is what you've been seeing where they take a swab of the inside of your nose, or they take some of your phlegm or a swab of your throat. That specimen is sent to a lab where they would isolate the particular genetic material. So you can see here in my drawing that there is a drawing of the genetic material. Hold on, let me pull up my mouse. So you can see we're trying to isolate this red material here, which is the genetic material. Think of it as like the fingerprint for the virus. It then goes through a process, very technical process that happens in a lab where they try to isolate the genetic material, and then after that they take it through a process called PCR, which is essentially like photocopying that genetic material to make sure that even if it's only in your specimen in trace amounts, that we'd still be able to detect it. And at the end of that process, you're either positive or negative for COVID-19. And there are a few limitations to this process. One is that it's very tedious in terms of the process and the steps, and very technical, which means that you need a very specific type of lab to do this. It's not just any lab that can run this test. You also need very well-trained personnel. So personnel who are able to safely inactivate the virus. So to make sure that they themselves are not getting infected, and then who can run the specimen through the entire process. And that's really been the limitation why we haven't been able to expand our confirmatory testing capacities as fast as we want to in the country. I think we all know that testing is an important component of managing this pandemic, but we do have these limitations in terms of how to set up confirmatory tests, which is why over the past few weeks, months, people have been talking about rapid antibody test, which is the one that you're seeing on the right-hand side of your screen. It looks like a pregnancy test. It works like a random blood sugar test, if any of you have done it. So they would take a sample of your blood either through a finger prick or through a venous straw. So they would take some blood from you, and then they would take that drop of blood and put it in what looks like a pregnancy test. You would then get these bands, and they would result in determining whether or not you have the presence of particular antibodies. And there are two types of antibodies. There's an IgG, this one that you're seeing over here, and an IgM. So you can see from here that based on whether or not those bands appear, you would be positive or negative. And this test has several advantages. One is that it's cheaper to do, and it only takes 10 minutes to get your results. And you just need a doctor or a nurse to administer it, so you don't have to go through a specific type of lab. And that's why a lot of people have been particularly interested in this test. That being said, I hope you allow me to take some time to take you through the principle of it so that you can understand also what the limitations are and how this test is imperfect. So in this diagram, what I'll show you is actually what these tests are measuring. The yellow line that you're seeing over here, which I'm tracing right now, that is the viral load in your body. That's what the RT-PCR test is looking for. You'll see that this blue line is your antibody. It's your IgM antibody. And you'll notice it's the first to go up. IgM antibodies are typically indicative of an ongoing infection and active infection. And then you'll see that it's followed by your IgG antibodies going up. IgG antibodies are typically indicative of a past infection. So JP has a mnemonic for this. I think he says it's IgM may sakit, IgG gumaling. And so the principle behind it is that depending on what you would get in your rapid testing results, if you're IgM positive, it could mean that you have an active infection. If you're IgG positive, it could mean that you have a past infection. But look at this window period right here that you have in the middle. And that window period is a period wherein you have both your IgGs up, your IgM and your IgG is up, and then you also have viral load. And that's the critical window where a lot of people are saying it's a gray area, right? And so that's why you also get a lot of question on how to properly interpret the test results. Another issue that you might have heard about in terms of rapid tests is what's called a sensitivity and a specificity. And a sensitivity and specificity are the ways that we measure how accurate diagnostic tests are. And sensitivity is basically a measure of how good your test is at detecting true positives, so people who really have the disease. While specificity tells you how good your test is in detecting true negatives, people who do not have the disease. And you have different types of sensitivities and specificities. And the concern really here for the critics of rapid testing is the possibility of having a false positive result, meaning you come out positive on the test, but you don't really have the disease, and a false negative result, meaning you're negative on the rapid test, but you do have the disease. And so that's why we have always said that to employ a rapid testing approach, you need to couple it with confirmatory testing. So you can see here that how we would interpret this is anytime that you are IgM positive, we would send you for confirmatory testing to confirm whether or not you truly do have COVID-19. There's a couple of other contentious, I guess, discussions around how to interpret IgG positive individuals. So if you're IgG positive, does this mean that you're immune for life? Could you not get COVID-19? And the truth is we don't know that today. We're hoping that if you're IgG positive, then that indicates a long-standing immunity. But honestly, it will take a while before the studies really show that you would be truly immune to the virus. And you might have been hearing about case reports reports or anecdotal reports of reinfection. And then finally, if you're antibody negative, then that just means that you don't have the antibodies that are being tested for this. So that is just your crash course in the principles of it. I think more importantly, I always like to share this slide to just ground people and to let them know that there are a lot of things that we don't know about COVID-19 in itself. And there are a lot of things that we don't know about rapid testing. And this is the reason why you'll see medical professionals and public health experts give a very, I would say, restrained recommendation on when to use this, right? So I'll take you through this because I really spend time making sure that people understand the strengths and limitations of this. Number one, on the left hand side, what I've done is to put what we know about the body's immune response to COVID-19, and on the right hand side, I want to take up issues specific to the test itself, right? So headline of this slide being, there's a lot of things that we don't know about how the body responds to COVID-19. And there's also a lot of things we don't know yet about how testing works specifically. And both of those limitations weigh into how we should be critically thinking about when to use these tests. So what we know is that typically the immune response of your body proceeds that way. It follows with your IgM first, may sakit, and your IgG, gumaling. But what we don't know is the exact timing of when those IgMs and IgGs go up and when exactly that overlap is. The second thing we don't know, which I mentioned, is how long that immune response lasts. Again, we talk about mutation. With COVID-19, it's caused by an RNA virus, which is very prone to mutation. And we also don't know yet how to deal with asymptomatic patients. And I will tell you that this is one of the most hotly debated topics in the medical and in the public health community, how to deal with asymptomatics, whether they're infectious, should you be testing them, and this is really a gray area for now. On the right-hand side, we do know that the advantage of using a rapid test is it's faster, it's cheaper, it can be done even without a complicated lab. We also know that you can be more, intelligent about choosing which tests you would use. So different tests have different types of sensitivity and specificity. So you should really evaluate the type of test that you're buying. And there are, I think, 9 FDA-approved rapid tests available in the market today. But there are things that we don't know. So the sensitivities and specificities, even if there are manufacturer-rated sensitivities and specificities, these still need to be tested in a broader population. We also don't know cross-reaction potential. So for example, if you're IgG positive, does that mean that you have antibodies to COVID-19, or could you be having antibodies to another coronavirus, let's say SARS or MERS, which are also coronaviruses and the sisters, if you will, of SARS-CoV-2. Finally, we also don't know the detection limit. So these tests will just give you either positive or negative. They don't tell you the levels of antibodies that you have. So as we in the public health side say, it's important that you're grounded on evidence, right? And we presented this to our leadership team, and these are the types of information that your own leadership team should be aware of. Which brings me to how we in the Ayala Group are thinking about implementing this. I think to frame it for everyone, at the core of our testing approach is what we feel is our fiduciary duty to keep our employees safe. And that's really the heart of it. We've reviewed the guidelines. We've talked to several doctors. I will tell you that for every doctor that tells you that you should be doing this, there's another one who will tell you that you should not. And so it's important that you try to distill through the evidence and understand what your own needs are as a organization. And so what we've come up with is what we feel is a very rational middle of the ground approach, where we would do selective testing and we would combine rapid antibody testing in conjunction with confirmatory testing. And what we would do is we would stratify our employees into select groups. And for each group, we would recommend certain groups to go rapid testing. And based on what the results would be, we would send them for confirmatory testing. So just to give you an idea of what those groups look like, you can see that we've identified 3 test groups here. Test group 1 are groups patients for which we feel there's a strong clinical need to do the test. So these are patients who are confirmed COVID cases, who are symptomatic or who have known exposure. And so for these people, there's really a lot of clinical value to give them the test. And we would designate them as test group 1. If you're monitoring the terminologies, this would be your PUIs, PUMs. In the new terminology, it's suspected and probable cases. There's a second group, which is in the Ayala group, we have a lot of frontliners at the moment, about 11,000 frontliners, not just our medical professionals, but also our bank tellers, for example, our Globe engineers, Manila Water Service engineers. And they've really been out on the field. And so we treat them as a high risk of exposure. We group them under test group 2. Now, the critical test group that has really, I think, will require a lot of discussion and further thinking from everyone is what we call the test group 3, or the test group that's eligible to re-enter the workforce. And how we've approached it is, one, the critical question that you need to ask is there really a need for these particular employees to re-enter the workforce, right? And then after that, you take on an extra layer and assess what is the individual risk profile of this patient. At the Ayala Corp, we've taken a hard line to say that anyone 50 years old or above, anyone with comorbidities or pregnant, we would not allow them to re-enter the workforce just yet. The important box that you're seeing here is this box up here that says work from home. And I think what we want to emphasize is a testing strategy does not replace the need to do social distancing. It doesn't replace the need to do quarantining, to do symptom monitoring, to triage appropriately. And so where we can, we would still recommend that people work from home. You note that we also have this orange note here that says BU discretion to include contractors and dependents. And that's because even if you're testing your employees, if they're interacting with contractors at your workplace, or if, for example, they have dependents at home that are high risk, then that would also be a consideration as to whether they should be tested or not. Just indicative numbers to give you an idea within the Ayala group of how many people we have that would fall under each test group. We have about 600 that would be under test group 1, another 11,000 of our frontliners. TBD, you can see in test group 3, and we've left it to our business units and their leadership teams to really think critically about who needs to come back to the workforce. And then just to say that there's still a group or a majority of our employees who would need to continue to work from home. We are leveraging our healthcare network, our platform, to be able to deliver these services. So you would either go to one of our clinics, or we could set up a mobile van, or we would work with your corporate clinic to set this up. And that's how we would do it. This is a very busy slide, but suffice it to say that we've come up with an algorithm. It starts out with putting people into appropriate test groups, so either test group 1, 2, or 3. If you're part of these groups, you would be sent for either a consult, or you would be sent to do your rapid antibody test. After which, depending on what your results are, you can either be cleared for work or you can be sent for confirmatory testing. And I want to underscore the importance of confirmatory testing. We know that rapid tests are not diagnostic, and therefore anyone with a potentially positive result would still need to undergo rapid testing. And we talked about the need to do this on a regular basis. So remember that these rapid tests capture a point in time, and it's possible that, you know, after you take the test, you'd be exposed again. And that's why we're going to be doing this on a regular basis. Our hypothesis for now is we would pilot this internally for 1 month. And during that 1 month, we would test our employees on a weekly basis. And based on the findings, we would then refine our protocols further. So just to give you an idea for the overall patient experience, you would be assigned a test group by your HR. HR would then designate you to go to one of the clinics at a scheduled date and time. There you would be triaged and you would undergo a consultation just to make sure that you're in the right test group and that you're aware of the process, get your consent to do this. Next, you will do the actual rapid testing. As I mentioned, it's just a finger prick or a venous draw depending on what test kits you're using. And then it just takes 10 minutes to get the result. after which you would sit with your doctor and they would walk you through the interpretation of this. And as further management, either you would be cleared to go back to work or you would be sent for confirmatory testing, and then the cycle would repeat itself. So that's how we're thinking about it today. I think to end, and I think you probably have more questions now than when we started out, but just some things that you need to think about if you're thinking of doing this in your own organization. One is that you need to approach testing holistically as part of a broader program. And that goes back to the 4Ps that we mentioned. Second is you need to really think about this as a long-term intervention. So it's not something that you can do one time and that would be an automatic solution for your workforce. Finally is that there are also scientific considerations. So make sure that the test kits that you're using are the ones that are FDA approved, because there are some in the market that are not. Do your homework, do your research on the test kits, and also to be sure that you're doing this in conjunction with confirmatory testing. Second is really to talk about the need for re-entry and to determine the need for re-entry. And, there are several things to think about. One is intrinsic work factors, or what we like to call the criticality of the work. So how important is it for the employee to physically be at work, and how important is the work that they're doing in terms of whether it's core to your business. Second is employee factors themselves, right? So think about, and this is a little bit tricky because you would have to do it almost on an individual employee basis, right? Like how does your employee have high-risk family members? Do they commute do they take on a long commute and therefore could potentially be exposed over a longer period? And then earlier we mentioned age, comorbidities, whether they're pregnant or not. All of these are factors that you would need to think about also. Third is you would then go into stratifying and think about the numbers of people that you would test. And certainly there are cost implications to this that you would need to consider. Finally, is this also sits within your broader framework of relevant policy. So in as much as we're thinking about our employees who are re-entering, we also need to make sure that we're taking care of the employees who are working from home. And whether that's thinking about your leave policies, your compensation policies, that needs to be part of the discussion too. I think to end, I'll let JP wrap it up and just to take you through a couple of more thoughts that we had on how to think about this for your own organizations. JP?
There you go. Thank you, Rizzy. Yeah, I just wanted to share this slide from the BCG group. I asked the permission of Anthony with John here. But they have a very good framework, no? And if you can see, the question is the first question is when, under what context would an employee be allowed to return to the workplace? This assumes, of course, that the ECQ has been lifted. In other words, the clearance has already been given, you can go back to work. The first question really should be when should they be allowed to go to work? No? The second is, which employee cohort should return to work? And Rizzy already gave you some idea of what that would look like. No? And some of the criteria could be things like the degree of interaction required by certain groups of employees, the reach of their work. In other words, is it just single location or do they go out? So for example, sales versus, no, not yet, just leave it first there. Back one, Rizzy. Reach of the work, their operational readiness, looking at prioritizing the needs, and looking at all of this in a holistic sense. No? The third question is the how. What intervention should be taken to ensure really a safe work environment? And again, Rizzy talked a little bit about that, and so did ASEC, CUCUECO earlier, no? In terms of making sure that you have hand sanitizers, you have PPEs, you're able to practice social distancing, and all of that should actually be taken into account. No? And then lastly is where, no? Where, because different sites may require different responses. So on the next page, these are just, again, this is just some of the initial ideas that we had from an HR standpoint and a planning standpoint. We already looked at the preparation for re-entry. We already said that for employees, we will apply the 4T framework, but the focus is on risk assessment. I coined the term essentiality. In other words, really which are essential, and if they can continue to work from home, work from home. That's really our default. If they have to go to the workplace, then the question should be, how are we going to now segregate them, and we'll do the weekly testing. But also we have a tech platform for health monitoring and clearance, so that there's a base questionnaire that will find out, do they live with a high-risk employee? For example, let's say their spouse is a healthcare worker, or their parents with a very high dreaded disease actually reports, or critical care actually reports for or lives with them, and so therefore that would be considered a high-risk household. Obviously, in the workplace, we're talking about access controls, preventive measures, sanitation. All of that's important. And then lastly, we've been aggressively shifting all our operations as much as possible to cloud, and to actually look at putting in place a lot of the productivity tools that we can have. No? Of course, we still have businesses like construction, manufacturing, hotels. We run an airline. All of those we have to actually revisit, like I said, in those three buckets: preparing for re-entry, looking at what we need to do in terms of changing for resiliency, changing our processes, and then of course also understanding how those will change, and therefore define what is the new normal. So with that, I think we can wrap up the presentation and really turn it over now to Rack, our moderator, for questions. Thank you.
Okay, thank you, JP, and thank you, Doc Rizzy. There are many questions here. I'll start off with those that are pertaining to Ayala related. Okay, so some were answered, I think, earlier by Rizzy, but I think it's just worthwhile to repeat the question for the purpose of being able to answer them. Okay, so first one is, are you going to do rapid antibody testing to all your employees, Ayala group-wide?
As Rizzy said, the intent is for that will be stratified. So if you're in risk category 1, yes, that's about 600 people. If you're in risk category 2, yes, that's about 11,000 people. And then for the remaining 75% of the workforce, we will prioritize those who need to come to work to be tested. To be honest, we're looking at about 30 to 40% of the workforce in our initial estimates who will continue to work from home. So in those cases, we're still looking at the protocol, but the intent is, even if you're working from home, at some point we do want to get you tested.
Okay.
So the answer is yes.
All right. Okay, for the rapid testing, and I suppose this is for Rizzy, the testing should be done together with the doctor, correct?
Yes, that's right.
And is the rapid testing conducted through blood extraction, or it can be done through pricking? You mentioned it can be conducted by a nurse. So is it not necessary that a medical professional conduct it?
Good question. That's one of the issues that we're looking at. So first, on the question of who can do the rapid testing, our recommendation and the way we're going to rule out is at least a nurse and a doctor. The reason why we would want the doctor there is because, as I mentioned, the interpretation of the results is not always as straightforward, meaning the doctor would need to consider things like your past exposure, do you have any symptoms, etc. So it's important to have the doctor there. In terms of whether it's a finger prick or a venous blood draw, if you read the manufacturer guidelines, they will recommend that you use a venous blood draw. But I have seen suppliers and other local distributors saying that you can do it with a finger prick. Now, we're validating internally. What we're doing is we're validating on our own whether we will get the same results either way. But just to say that they were tested on venous blood, and finger prick has that additional, some people say that, if you take a finger prick, you have to take into account that it could be contaminated with other fluids, your skin tissue, etc. And so I would double check with whatever test kit you're using in particular as to whether or not they've been validated with finger prick blood draw.
Okay. Now, this is regarding contact tracing, and I suppose this can also be directed to Dr. Rizzy. Will it be okay to conduct a contact tracing regardless if a person is symptomatic or infected? For example, having them log people who they had close contact with within the day, so that if there is a case that arises, the contact tracing will be easier later on. Are there any deviations from DOH or Privacy Act to do this?
I'll answer from a medical point of view, and then I don't know if JP will comment on the Privacy Act part, employee
Sure,
privacy,
I can do that.
HR concern. From a medical point of view, definitely there's value in contact tracing. So we know that this is a disease that's transmitted person to person, right? And anyone that you've had sustained contact with could potentially get it from you. And anytime that you have somebody who's symptomatic and then they get confirmed with the disease, then you should definitely do contact tracing.
JP?
Yeah. Let me answer that. No. I think the first question, if you go back to one of the slides of Rizzy, it's our fiduciary responsibility to keep our employees safe. No. And so I think part of it is a culture that you need to create in the organization. So in our case, there's a whole area of malasakit that needs to come in. That the reason we need to be able to trace is because one, you could have been infected by somebody, and therefore we need to be able to identify you in the event that somebody that you had been dealing with was infected, and therefore we need to make sure that we can continue to protect you, right? The other one is your own responsibility also to others, and that if you are symptomatic or you develop symptoms, we need to know that as well, again, for the purpose of being able to make sure that we're able to address it. No? We always say the reason we've done the 4 Ts is we need to increase our ability to identify the employees that are at risk or that have been infected, the ability to isolate as a result of the triage if we do that, and the ability to now treat them and therefore able to now prevent a community spread within the workplace. I think that's really our base for the tracing. And so I mentioned earlier about using technology. Some of our companies already have daily questionnaires that they're asked to fill out on their mobile phones or on Facebook Messenger that they're basically asking, has there been a change in your symptoms or in how you feel from the last time that you actually reported? Do you live with somebody who is actually high risk? So we take that all in as part of the data analytics so that then we're able to now isolate and identify if an employee needs to be isolated, needs to go for confirmatory testing or etc., and able to handle accordingly. We're also using, again, once the workplace is open, we're also going to start looking at things, again, for tracing purposes, information that's already in the workplace. Things like biometrics or people that have been badging themselves into the workplace. You can actually look at Outlook calendars of who were present in a particular meeting room in the event that somebody was actually diagnosed as a potential case. So there's a lot of information that's already in the workplace that we should actually be able to do. But again, I think everybody has to understand that this is not us to find out where you've been, but it's really in the event that we need to trace you and to track you for your own good. Then this is really how we have to do the tracing.
There is a Stay Safe contact tracing app, which is one of the features that people are supposed to get. People are using this to get medical advice to be arranged by LGUs. Have you heard of this? Stay Safe contact tracing.
Yes.
This was intended for Dr. Rizzy, but you have heard of it. And the question is, can Ayala Corporation help in with this app and see if this is something that can be offered to people? Is this one of the digital? I suppose one of the digital. I guess one of the technologies that you're using today.
Right. Yes, we've heard about it actually. And the group, we have a tech team within the group that's looking at it. Our data and analytics team, they're looking at all of these possible solutions. They've also been working with Globe to look at what are the existing apps. And there's, I think we're still putting together an inventory of how we can help out with these particular apps. But we're within the group, we're also building out our own solutions for our employees.
JP, this is for you. Can you share what specific questions are included in the daily monitoring questionnaire to be answered by your employees? Can you share that with us?
Yeah, like I said, there are two parts. No, the first part is what we call the background baseline. And when you say the baseline, it's again the things like age, where do they live, the usual demographics. But it also talks about are you does a healthcare worker live with you? Do you have parents that are in the high risk category, over 50 or over 60 with comorbidities? So all of that is what we call baseline, and that's a questionnaire that we ask all employees to fill out. But for the daily check, it's really more the question of where did you go out? For example, did you go out yesterday, and were you in public? Did you take public transportation? Did you feel any changes in your health condition? If so, is it a fever? Did you start having a cough? So all of those questions are now done. And the technology is great because then we're actually, in some cases, we're deploying chatbots. So it's text-based. They just answer by text, and then it's a back and forth. In Globe, they're using an app. So we're all putting this together. As Rizzy said, we have a technology team that's actually looking at this. Because again, to put things in numbers, I think Rizzy didn't put that in context when she said that there are 11,000 people and 600 people, etc. We have 56,500 full-time employees. Those are our direct hires, no? Then you have to add about another 100,000 partners who are not our employees but yet work in an Ayala business. So this could be the construction workers. These could be the people in our malls and running our offices. So these people, while they're not our direct employees, we need to make sure that they're also included in the healthcare tracking because they will be in the workplace. And so we need to be able to also track them. And that's why we felt that we needed to develop the technology to be able to track that on a group-wide basis.
Okay, so some questions here were I suppose answered earlier, like do we see the wearing of face masks for office-based employees as part of the health protocol post ECQ? That was from Ruth Angeles and Nick Lim, and the answer was yes until we can find the vaccine, right? That was the answer of Dr. Tess earlier. So I will have to remove that. Okay. Okay. Okay, so here's another question. But I suppose this can be given to or directed to Dr. Rizzy. Will there be a standard protocol guidelines for handling workers who have symptoms similar to that of COVID-19? Do we need to subject them to a 14-day quarantine?
Yes, I think the standard guidelines right now is anybody who exhibits flu-like symptoms would need to undergo a 14-day quarantine. So by flu-like symptoms, we mean fever, cough, difficulty breathing, fatigue, muscle pain. These are some of the symptoms that we see. So that definitely for those people, they shouldn't come to work and they should comply with the 14-day quarantine period.
Okay, what about what is isolation process for those who suddenly feel ill at work? What should they do? Can you give a step-by-step procedure?
Right. So for those who suddenly feel ill at work, I think the important thing is to be able to isolate them immediately. So if you have a company clinic where they can be seen by a doctor, then they can be assessed there. If not, then they should be immediately sent home. Subject, of course, that they don't need to go to the ER or let's say their symptoms are not so severe, they should be sent home. I think what some people forget is that when you're sent home to isolate, you should be isolated in your work in your house as well. So you have to have your own room. You shouldn't be interacting with other people in your house, like the common areas like the living room, the kitchen. You should, as much as possible, try to stay away, especially if you're living with high-risk individuals. So for those people who were in the workplace at the same time as the person who had symptoms, I think the important thing is just to clean the workplace, so disinfect. This virus is not particularly resistant to cleaning, so just normal our normal cleaning agents just work well to kill it. So just clean the surfaces, and then continue to monitor whether you would develop symptoms or not. I guess that's the importance of practicing that social distancing, right? We know that people can develop symptoms, and so you try to minimize your interaction with others as much as you can.
Okay, a follow-up question. How do you handle unexpected asymptomatic employee who becomes positive? Is there possibility for a total shutdown of company?
Actually, it would depend, I guess, on who that person has interacted with. I wouldn't make the fact that you have one positive case the sole basis to shut down your operations. I would think first about where that employee has been. For example, if it was just one particular office, then it's just that office that needs to be cleaned, and then just contact tracing that needs to be done for whoever that employee came in contact with. Based on the guidelines, you can just clean a particular area after an hour or 2 hours at most. When the area has been cleaned, then people can go back to work and resume their work. So it really depends on contact tracing that you're doing.
Thank you. Next questions would be for JP or Beta. From a business perspective, what is your reaction regarding ECQ extension for critical areas? How will this affect business? Are foregone losses? How do we? Okay, let me rephrase the question. What do we do with foregone losses? And is there no pressure on government for not allowing non-essential manufacturers from operating?
Oh, that's a lot of questions.
Yeah, let's start with what is your reaction for the extension? About the extension for critical areas?
Well, I think if you remember when I started, I did not put a date on when the extension or when the ECQ would be lifted. We specifically said that we need to be ready for this to be extended. Even the May 15 is no guarantee at this point. I think the government has already said that until cases really start to come down, you know, they may reassess that again, and so that's why this is a moving target. So unfortunately, that's the reality of the situation, and so that's why, if you remember the framework, we have been planning for whenever it is going to be lifted. Now, and that's why, if you recall, in the second column that I had, which is under the modified lockdown or modified community quarantine, we actually ask our businesses to look at their scenario planning: best case, worst case, base case. What happens if you're not allowed to operate until the end of the year as a worst case? And so we need to actually have a better handle on that from both a business and a financial standpoint. And so this is why it's important to actually have a framework in mind, so that then you can run those scenarios. Then it begs the question, and therefore, what do you do with the workforce? How do you start minimizing now your exposure? Do you need to now start looking at working capital? Is this the best time to now start investing? Because and doing other things that you didn't have the opportunity in the past to do. Sometimes crisis also provides opportunities, and I think that's the stance that we've actually taken in that second column. What needs to change in terms of just the business operations, so that then we can look for opportunities.
Here's a follow-up question pertaining to what you guys have done in Ayala. Did Ayala consider your people's usage of mass public transportation and thus risk of exposure in determining the different test groups if these individuals will be considered for testing? I think we've answered this earlier, no?
Yeah, we've answered that. Yeah.
Yeah. Okay, hold on. There's one also.
Yes,
that,
the answer is yes.
Okay, so this is...
The answer is yes.
Okay, so the framework that you have, this is really for big corporations, according to Dante Briones. Do you have any suggestions for small ones like theirs? I guess this is for JP.
No, I think if you think about us, we have a lot of small companies as well. And I think the question is, do you now look at your workforce, and therefore the question is, how do you continue to protect them? That's why it's important, that principle that Rizzy showed, no, which is our fiduciary responsibility to protect our employees. And so even for small companies, I think the 4 T's could still apply. No, triage is really, like I said, in the event that you now have somebody that's not feeling well or that is ill, what are their options? Where do they go? How do we assess whether they need to be tested or treated? And that goes through that whole process. Yesterday, Francis Lim and I were part of the Project ARC discussion about increasing the availability of rapid test kits, both by companies, big and small, so that you have access to rapid test kits, but at the same time, even asking employers to actually donate and help barangays, help to do rapid testing at the barangay level, so that then even employees and who live in a barangay will have access to rapid test kits. So I think that's another area, and I don't know, Francis, if you want anything to add, because MAP has made a decision to actually support Project ARC.
Yes, as I stated in my introductory remarks, we're encouraging our member companies to participate in Project ARC and see how they can help in the barangay level testing and implement rapid testing at the company level. It's so important because these two really go hand in hand in helping determine whether the ECQ will be lifted even on a selective basis and what companies must do once the ECQ is lifted in their workplace. So I'm about to sign a circular directed to our members, encouraging them to participate in Project ARC. So I'll include some remarks in my closing statement, JP.
Okay. Here's another question for you, JP. For Ayala Corp, how did you do the risk profile assessment and getting the sensitive information from all your employees? Was it mandatory or voluntary for them to provide the information? The questions were asked by Joseph Villordon.
Like I said, I think part of it is just the culture of trust. I think in our case, the employees actually volunteered, to at least those that we've already rolled out the questionnaires, voluntarily supply the information precisely because they felt that they needed to be able to feel safe. And it's only if everybody participates will we be able to protect them in their workplace. So I think there's that level of trust that has to be established first and foremost. And I think that's why there's an education part as well on why it's important that we get this information. And like I said, it's really for their safety and health that we're doing this. And so the questionnaires are, like I said, are fairly straightforward. Globe just pings them every day and says, it's time for your health check. And then this has just 3 or 4 questions, quick questions. They can do spot surveys. But basically, it's that having that ability to gather that information and keep and give that feeling that the employees feel that they are safe and that they're being cared for.
Okay, here's another interesting question. In terms of your testing procedures for other companies who have branches all over Metro Manila, can we partner with your clinics? We don't want them to go to the hospitals anymore. How do we go about this? And there was a related question pertaining to what are the requirements for your clinics to prepare them to conduct these tests. And these questions were from Edoberto Eller Dizon.
I think what we're doing is we're going to run this process internally first. So we want to make sure that, we've validated the test kits that we're using and that we've sorted out the operational guidelines to it. After which, that's when we would open it up to third parties who would want to avail of this service also. So maybe just give us a month or so to iron out the details, and eventually when we're ready, we'll be opening it up to more people as well.
Okay, thanks. There is a question from Patrick Reidenbach. A vaccine can take years to develop and distribute. Should this really be the basis for return to normal? What do you think, JP?
No, I was going to ask Rizzy to do that because from the vaccine, maybe you can talk a little bit about the life cycle of that.
Right. Sure. Well, when you talk about the goal with vaccines is to be able to immunize as many people as you can, right? The goal being that if you're immunized, you wouldn't be able to get COVID-19 anymore. And vaccination is one way to do it. The issue with our vaccines is that it takes years to develop, as JP mentioned. The normal timeline is maybe 5 to 10 years to develop a vaccine. And we're trying to accelerate that to a year. And so you might have seen articles that say that you would have a vaccine in 9 months. I honestly think 9 months is very optimistic. Probably the vaccine that you would have in 9 months is still something that would be on a trial basis. So a year is the most optimistic, and then you have to think about mass producing that vaccine, right? Because everybody will need it. Throughout the world, everyone will need it. And so supply will also be an issue. The other school of thought in terms of how to get immunity is what's being called herd immunity. And some of you might have heard this. After a period of time, enough of your population will have had the disease that that more or less you'd be immune to it. So even if somebody in the population gets it, it won't spread around as fast. And that's a topic that's also very much debated in the public health community. Some countries like the United Kingdom in the early days had said that they were taking a herd immunity approach, meaning they were just going to let people get infected. And what happened is over time, they ended up with more and more critically ill patients, and they have a limitation also in terms of their health facilities and healthcare workers. And that's the situation that we don't want to get into, right? And so I think it's difficult for a country like us where we have limited healthcare resources, we have limited healthcare personnel, and the ECQ right now is our way of buying time for our healthcare system to be ready, and then also for us to I guess wait and see when that vaccine or when any other experimental treatments will prove to be more promising. So for now, the vaccine is probably our best goalpost, if you will, of when we can completely go back to that normal. In the meantime, it's, I guess, ramping up our healthcare capacities so we can get to a level where at least we can deal with new infections that would come up.
Okay.
Maybe just to add to that,
Sure.
Rack, because there was a question that I can see on the chat from Peng Perez de Tagle that's related to the herd immunity question on Sweden. No? Some of you may have heard that Sweden did not lock down; they kept their economy going, and they were the ones that's very aggressive about building herd immunity. Unfortunately, there's also been a lot of talk that did Sweden take too much of a gamble because they have the highest death rates. That's coming out in Europe now, because then again, that was the gamble that they took, that they didn't want to lock down the economy and allow the virus basically to take its course, and so they have one of the highest death rates. So the question is that appropriate for us? I don't think so. I don't think we're anywhere near the capacity of Sweden, even a country like Sweden, who has very good facilities to actually be able to outbreak. So back to the question of Patrick, as far as we're concerned, I think that's the reason why. Let's face it: the moment we open the moment we lift the lockdown, there will be cases. I think we cannot lull ourselves into thinking that we've done everything and therefore cases will not spread. But we can't also be a hermit state forever, and basically just continue, not working. And so I think the question now is, I go back, the reason we're putting the protocols in place of triage, testing, treatment, and tracing is so that we're able, like I said, to identify the people that are sick, be able to test them, to treat them, and hopefully we'll be able to stop a further spread by isolating and able to handle that, while we have the capacity to handle it. So I think that there really should just be the framework here. And that's why I go back to what I said in my original slide, original remarks, which is preparing for the new normal. And if that means that the new normal means that 30% of your workforce is not coming to the workplace and working from other places, then maybe that's what the new normal would look like.
Okay, last couple of questions. How is, okay, hold on now. So this is from an anonymous attendee. How is Ayala addressing the mental health concerns that, wait, hold on. Okay, how is Ayala addressing the mental health concerns that arise because of the pandemic and the lockdown?
So mental health is really a huge issue in this situation. I think there are a lot of stressors in this situation. One is dealing with just COVID in itself, right? So the pandemic, the numbers that are rising, a lot of us, we might have felt that, you know, this disease is getting closer to home. We might know a family member or a friend who's been sick, or heard of someone who lost a loved one or lost a loved one ourselves. And that's very stressful in itself. The other major stressor is, of course, dealing with this whole quarantine and isolation situation, right? Where we're not doing our normal day-to-day activities. We're not seeing the people that we normally used to see. And so that can take a mental health toll, definitely. I think within the Ayala group, what we've done is really to empower our individual teams that despite the fact that they're working from home, they should still maintain some form of communication, some line to make sure that, you know, they're checking on their teams, they're doing regular catch-ups, because that goes, that's something that needs to come from the top and then all the way down to be able to get it to the individual level. And then, of course, your mental health is mental health needs you to have the supportive environment around it. So making sure that we're communicating regularly with our employees, that, you know, we're developing policies, we're developing guidelines that have your safety and well-being in mind, that hindi ka mapapabayaan dito, right? No matter what the situation is, we would look after them. And so I think those are just our ways of being able to address it. More directly, we do offer our hotline services. So if anybody needs a consult, including mental health consult, then they could do that as well.
Okay, thank you, Doctora. So here's one last question from Bruce Rodriguez. What can the private and public sectors do now that the ECQ has been extended for some places while the lockdown in lower risk areas may be gradually eased up? Can they already make preparations to make sure the eventual reopening of all businesses will be seamless while making sure the virus won't be spread again? JP or Doctora?
No, yeah. Let me start with that. I think there's a lot that the private sector can do to help government. You know, I think the focus in the past has been providing PPEs, no, masks, and actually no. The first wave was food. If you remember, everybody was giving food to the frontline workers. No, then the call became for PPEs and masks and all of that. Now, again through Project ARC. They're asking companies, the private sector, to help fund the purchase of rapid test kits. And that's why, as Francis said, they're encouraging companies to not only purchase rapid test kits for their employees and their families, but also to help fund it for the barangay level. Some of the companies have actually started helping the public sector by in the purchase of PCR machines and setting up labs. No, right now there are only 17 accredited labs that the DOH has released. The intent or the desire is to actually reach 50. And so there's still a big opportunity to help the hospitals develop some of the capabilities to do that. And it's a process, as Rizzy can tell you. Because you take level 2 labs, so that can handle both the molecular testing for the PCR machines. You have to buy the PCR machines. So there's a lot of things that need to go into really helping us ramp up. If I remember right now we're doing about 3,000 tests per day. That needs to go to 30,000 tests per day per place, no, or per area. No? So we still have a long way to go in terms of just rolling out rapid testing at the community level. So I think back to the question of Bruce, there really is a lot of opportunity for the private sector to partner with the public sector. And like I said, I think part of that is also preparing your own workforce and your own workplace. Hopefully this webinar has given you some ideas on how to help prepare, but that really is the intention. Rizzy, I don't know if you have any other comments to add to that.
Maybe just to add, JP, that I think one concrete way that we can help out with public health efforts is where we can to share data and to make sure that we're sharing, for example, if we track or if we find cases in our own workforce among our employees, to make sure that we're reporting that to the Department of Health and working with them to develop that. I think, as we mentioned, even when the ECQ is lifted, it doesn't mean that we don't need to continue to observe basic guidelines like social distancing, hand hygiene, and cough etiquette. So just prepare that even as you think through trying to get back to some semblance of normal, that it will be a new normal and we'll need to adjust to that.
Okay, thank you so much, JP and Dr. Rizzy, and really thank you for sharing your time and expertise with us today. This topic has been so interesting that we've had at some point 321 participants, and we still have about 27 questions that are open, but we can't answer them all given the time that we have. And so at this point, before we adjourn, may I request our President, Attorney Francis Lim, to give his closing remarks.
Francis, you're on mute. Francis, mute.
Okay.
You're okay. Up. Nope, back to mute.
Hello?
Yes.
Okay.
Yes.
Okay, thank you very much, Rack. Thank you to the participants for spending time with us, and thanks most especially to our speakers, Tess, CUCUECO of DOLE, of course, Dr. Rizzy and JP, thank you for the presentation. I think that key takeaway here is that, and I think this also answers the question of Bruce Rodriguez from ABS-CBN, is to start work now on your health protocol for your company while we are in an extended lockdown. As has been pointed out, there will be a new normal in the workplace, at least until the vaccine is discovered, which is still months away. And preparations, and this will entail a lot of preparatory work and even additional budget. You've heard DOLE USEC test say that rapid testing and mandatory wearing of masks will most probably be a part of the DOLE guidelines. And in fact, we may have to reconfigure things, physical space in our offices, because we've heard the good Assistant Secretary talk about avoiding face-to-face contact, even in the corridors and in the elevators. And I think the presentation of Rizzy and JP gave us a framework, which contains items that can be adopted by standalone companies or even much smaller companies than the Ayala Group. For example, they talk about workforce risk assessment, re-entry survey, antibody test, which is a lot cheaper than the PCR-based test. But if I understood it right, this antibody test will be combined with confirmatory tests based on the PCR test, and that requires some budget because PCR is much more expensive than the antibody rapid testing. And JP also talked about the questions when, which he calls essentiality, if I understood you right, JP. Who, how, what interventions have to be made by the employer, and where, in case of a multi-place branches or sites where the company is operating. Insofar as MAP is concerned, we're trying to adopt a holistic approach to this problem. That's why we have encouraged our companies, member companies, to join the Project ARC, because the Project ARC will really go a long way into achieving the massive testing that is a condition sine qua non for the selective or partial lifting of the lockdown. I think it's costing the economy. This is a calculation by Joey Salceda, one of the authors of the stimulus bill, that is sort about 19.5 billion a day per of lockdown. So you can just imagine how costly it is for us to be on an extended lockdown. And that's why massive testing, and this was also the position of MAP. JP is part of the MAP Board of Governors, that before we lift the lockdown, there should be massive testing and to prepare our healthcare system. So there's a lot to be done by the private sector in coordination with the government. For example, MAP also proposed a modified transport plan to go along with this selective or partial lifting of the lockdown. So there's a host of issues to be answered, to be addressed by our member companies, just trying to prepare healthcare protocol for the workers once the lockdown is partially lifted. As to when, we don't know, but we're hoping, we're keeping our fingers crossed that it will be done sooner than expected. On that, I'd like to close on that note, and thank you again, Rizzy and JP, RAC. Thank you to the members and to the guests for spending your time with us. Maraming salamat po.
Okay, thank you, Attorney Francis, and thank you for everyone. Thank you to everyone for joining us today. There is a lot of requests about slides to be shared and some answers to the questions that have been opened. So I leave that to the Secretariat to work on it. Thank you again, everyone, for participating in today's third MAP webinar. We are adjourned. Thank you so much.
Thank you.
Thank you. Thank you.
Bye-bye.
Thank you. Bye.
Bye-bye.
Good job, Rack.
Thank you, everyone.